This is a single axis image provided from a CT pelvis, contrast enhanced. So I'm able to appreciate that there is a cystic looking lesion in the region of the rectum with the with an enhancing wall. However, there is no internal necrotic component or no calcification. The adjacent muscles appears to be normal. There is no fat stranding. There is no lymphadenopathy in the region of the iliac vessels. The iliac vessels are of normal caliber. The inviewed wall of the abdomen is okay. However, I can appreciate that there is slight asymmetry of the muscles in the left wall of the pelvis. It can be due to a single slice provided.
Normal. Consider it normal.
Okay, sir. Okay, sir. The inviewed bones are also okay. So if sticking to this single pathology, which is looking like a fluid-filled cystic-looking lesion involving the rectum, the lumen is not very clearly visible to me. Maybe it is displaced or compressed due to this lesion. And there is also slight expansion of the right lateral wall of the rectum. And next, I would like to see further images. Also, if other projections are available, like corneal and sagittal images. And if I can be able to take some clinical history of the patient, if there is the patient is of old age, so it can be in it can be a malignant looking lesion, but it's not as malignant looking because there is no circumferential thickening. And I would like to first confirm the clinical presentation of the patient if there is any history of fever or other symptoms, like to rule out some inflammation or an abscess in this region.
You did the big mistake in the exam. You describe thing and you jump immediately looking for the coronal axial images and clinical scenario and other investigation, clinical history before you summarize, before you put your differential diagnosis, before. So I will start by describe the abnormality, then I will put the summary. So summary, I'm dealing with perirectal or rectal lesion. So my differential diagnosis is so and so and so and so and so. I want to put you have to tell the examiner, you know everything about the differential, you know everything about the case, so you will guide them to proper the treatment or final diagnosis for this patient. You ask me clinical presentation, you ask me about coronal images, you ask me, don't ask the examiner for the next step, or don't ask for step or ask for another modality unless the examiner he tell you what is the next step or what is your clinical history you want to know. You should ask. If you reach to the differential diagnosis and you will say, if patient, my differential diagnosis will be so and so and so. If patient has fever or previous surgery, I will consider seroma or don't throw it immediately before you said in summary and what's in your differential diagnosis. So please rephrase your descriptions and then we'll go further.
Yes, sir.
Yes.
So, sir, my first impression is now it may be likely a perirectal abscess.
No, don't tell me from start. This is what you see.
Sir.
What you see, then summarize. So when you get the summary, actually, when you have the finding and you put the summary, it was easy for you to put the differential diagnosis.
Okay, sir. Sir, there is a hypodense lesion, lobulated lesion with enhancing walls in the right lateral wall of the rectum, which is involving the lateral and inferior wall of the rectum. Also, the lumen is displaced towards the left and slightly superiorly. There is no perirectal stranding, no The adjacent muscles appears to be intact with no involvement of this lesion into the muscles, and there is no lymphadenopathy. So my impression of this lesion is it could be a collection in the region of the rectum, a rectal wall, or it can be a developing abscess.
What's more?
Sir, there is no internal necrotic components or no calcification. I cannot see. I cannot appreciate any septations or solid component.
So you said no necrotic component, and you say this is hypodense lesion. So there is overlap between two terms.
Sir, by necrotic component, sir, I meant to say that it's looking like a homogeneously fluid intensity lesion.
Okay. So what's more differential?
Sir, so it can be a collection in this region, in the rectal wall.
So collections, what's against collection?
Sir, likely an abscess.
What's against abscess?
So abscess is an inflammatory product after an infection, sir.
No, what's against abscess? Imaging wise.
Sir, localized collection, sir.
So abscess can be localized?
Yes, sir.
So what's against?
Sir, to sum it up, like, sir, for me, it's a benign looking pathology, to be precise, like. So I need.
So you will inform the referring physician. So
sir, to confirm my diagnosis, I would like to know the clinical history. If there is history of fever, it would be definitely then an abscess or a collection in this region. If there is a history of long-standing any kind of chronic illnesses like Crohn's disease or ulcerative colitis, so it can be a complication of that as well.
Like what complications? You mean this is perianal fistula?
Sorry, sir. Sorry, sir.
Could be perianal fistula.
Perianal fistula.
You said if patient has Crohn's disease, you will see complication of Crohn's disease like what?
Sir, in Crohn's, Crohn's doesn't really manifest in the rectum mostly, but in ulcerative colitis, the patients usually do have the initial manifestation in the rectum and the anal canal.
Rectum can affect more even the perianal area.
Yes, sir. Yes, sir. It can be affected, but sir, I'm talking about the complications in those patients. So even in those patients, if it's an inflammatory bowel disease, even in those patients, they are more prone to have abscesses and collections in these regions, sir.
What's more differential diagnosis you want to put it?
More differential, sir, if sir, it can be an extrinsic cystic lesion which is compressing upon the lumen.
Like what?
Like, sir, like a rectal, sir, sir, I'm not able to recall all the those lesions, sir. Exactly, sir. Like, sir, there are some perienteric cysts, like some terminology which I have.
I will help you. Rectal duplication cyst 1. What's more?
Yes, sir. Yes, sir. Rectal duplication cyst and sir, so it can be even of a neural origin here, sir, as some sympathetic ganglia also run in the presacral and the coccygeal region. But keeping in view those enhancement pattern, there is the possibility is least likely of any neural origin tumor, sir.
So if you say benign, we'll discharge patient. If you say malignant, we'll do further workup.
No, sir. If I'm talking about benign, I would like to keep the patient on conservative therapy, like antibiotic and observation. And I would like to follow up the patient if it resolves with the antibiotics and the conservative treatment, or either it can be followed up with the other investigations like even sigmoidoscopy and colonoscopy and biopsies can be taken. But if it doesn't resolve with the
so you will
conservative treatment.
How much?
Sir, after the trial of antibiotic therapy. Sir, can I ask for an MRI to rule out any discharging sinus or any other reason of this lesion to confirm it with MRI? Okay, sir. Sir, I'm provided with the corneal MR image. This is a T1 weighted MR image. I'm able to appreciate that there is the tract which is going up to the rectum from the skin. At the skin opening, it is at the 6 o'clock position. And there is a enhancing multi-septated in hyperintense lesion collection, which is pushing. Having a mass effect on the rectum, and there is a communicating tract seen which is going up to the skin. Okay, so these are the axial images and which are confirming my finding, and it is likely a perirectal collection with a fistulous communication reaching up to the skin. So the underlying systemic illnesses needs to be ruled out in these patients, because usually these fistulas and the such collections can be seen in patients with the chronic inflammatory bowel disease.
So let's start from the CT again, please. This is perisacral or pararectal cystic lesions. Okay.
Yes, sir. Yes, sir.
Will include abscess, hematoma,
yes, sir.
malformation, teratoma, dermoid, rectal duplication cyst, and I will consider in this patient also mucinous. Mucinous adenocarcinoma can be presented as collections. So my next step, I will do local MRI for characterization of these lesions. I will do.
Sir.
So this is the MRI. MRI showing large lesion with bright T2 signal intensity. This lesion tend to be fistulizing. From the characteristic behavior of mucinous adenocarcinoma, usually it is fistulizing tumor. So if patient presented later, you don't want to delay patient for 6 weeks, 7 weeks to make sure this is abscess or not. Usually consider mucinous tumor, even if patient has abscess or collection or discharge, you have to consider mucinous adenocarcinoma. This patient tend to be mucinous adenocarcinoma of the rectum, locally advanced.
Okay, sir.
Okay.
So I'm presented with CT scan abdomen axial section images, a plane and the arterial phase images are provided. In these images, I can see liver shows irregular margins and it appears cirrhotic. The spleen is also enlarged, and I can see ascites is also noted. In these images, I can see in the plane images, a irregular shaped hyperdense area is noted in the posterior segments of the right lobe of the liver, which is not showing any significant enhancement of the arterial phase images. Moreover, I can see there are few nodular lesions, one in the segment 4, in the arterialized lesion, which is well-defined rounded arterialized lesion, noted in the segment 4. This lesion is hypotense on the pre-contrast enhanced images. And so considering the background of the cirrhotic liver and CLD, I will consider this as a... sorry?
What is the pre-contrast?
Sorry, sir?
Where is the pre-contrast study?
Sir, the inferior image, second image, the first one on the top is arterial. And the second one is, no, sir, it is actually the portal venous phase.
It's portal venous or delay phase?
Sir, it's delayed.
So this is delay. Okay.
So the lesion in the left lobe is arterialized and it is showing washout on the delayed images, while the larger lesion in the right lobe posterior segments, it is not arterialized and it's not showing arterial enhancement, but it is still appearing hypodense. So the arterialized lesion is, I think, a dysplastic nodule, likely hepatoma.
You
it is showing washout.
So in summary, please summarize your finding. Summarize.
Sir, although in the background of CLD, I'm strongly suspecting hepatoma, but the appearances are not. Yes, the lesion is also showing arterialized. So I think this is multifocal hepatoma.
So can you summarize?
So multifocal HCC showing irregular arterial enhancement and washout on the delayed images.
If the examiner tells you summarize your finding, don't repeat your finding as the same. So I will say cirrhotic liver, and the summary cirrhotic liver with hypervascular lesions.
Sorry, sir?
I will say cirrhotic liver with hypervascular lesions.
Sorry, sir, I'm unable to. I'm not
This
understanding.
Is cirrhotic liver. In summary, we're dealing with cirrhotic liver with hypervascular lesions. Lesions shown wash in. This is wash in. This is wash out. Don't call it dysplastic nodule. This is HCC, 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 HCC. This is hepatocellular carcinoma. So, infiltrative lesions. Usually infiltrative lesions, they don't give us the pattern of usual HCC enhancement in the whole lesions. Okay?
Okay.
We have some lesions here, enhancing and washing out. So wash in, wash out lesion, this is HCC, HCC, HCC until proven otherwise. So next step, I will evaluate what? Portal venous system and vascular system. So the treatment plan will be change. So what's you see in the portal vein?
In the portal vein, I think there's enhancing thrombus in the portal vein.
Yes, excellent. So this is
tumor thrombus.
So what's LIRAD? What's LIRAD?
I have no idea about LIRAD. I can't apply them.
Anyone has idea about LIRAD? LIRAD is a way of reporting system like BIRAD.
I know that's important, but I can't recall them. These are the liver imaging.
Yeah, this is TIV, tumor in vein. This is tumor in vein. So HCC within the vein. Okay? So this is completely different. And also you should comment about the function of the livers. If you see ascites, so mean that's this decompensated liver. Splenomegaly indicate also portal hypertension. Okay, so what is your next step?
So, next I will send the patient to the hepatologist. I don't think that maybe they will consider TACE or for the hepatic transplant. But I don't think so. The hepatic transplant is suitable in this.
It is for tumor board discussion. Tumor board discussions.
Okay.
So,
okay.
Laboratory. What is your what you want to correlate with what?
Sorry, sir.
You want to correlate with what in the lab?
With alpha-fetoproteins level, obviously.
I will correlate with protein. So if you see cirrhotic liver in the, in the exam, you have to comment about the liver is cirrhotic or not cirrhotic. There is a lesion or no lesion. Lesion is hypervascular or not. Then I will evaluate the vascular involvement is involving portal vein, hepatic portal veins, hepatic veins. Then evaluate for extrahepatic disease. If patient has extrahepatic disease in the adrenals or in the bone, so they will decline from the transplant or other treatments.
Right, sir.
Okay?
Right. Okay.
Sir, I am provided with a single contrast, arterial phase contrast enhanced axial slices of the CT abdomen at the section of liver, in which I can see that non-contrast enhancing hypodense area is seen involving the region of yes, sir, seen involving the region of pancreas. Hello?
Yes, I'm hearing you. I'm with you.
Yes, sir. And it is not showing any contrast enhancement on its surrounding peripherally. The necrotic area is also evident. It is of fluid signal intensity with necrotic area causing some compressive effect on the left lobe of the liver, sir. Also portal vein or
portal vein is free.
Yes, sir. The rest of the pancreas appears normal.
Okay. So in summary?
Sir, I would like to take the history of some pancreatitis.
Don't ask for the history unless you want to confirm one diagnosis. Don't jump for the history. Because if you ask the physician, if you're reporting the case in the daily work and your physician come, this patient has dropping hemoglobin, this patient febrile, or this patient afebrile. If you throw many questions, he will thought this is not know what's going on. If you ask him, please, this patient has history of previous so and so. This patient has dropping hemoglobin. If patient has dropping hemoglobin, this is hematoma. If patient has fever, so this is TB. If patient, so unless you, when you reach to the differential diagnosis, then start to throw your questions to determine this is, so to rule in or to rule out diagnosis from your list.
Sir, okay, fine. As there are no peripancreatic fat strainings or also not evident, I would like to keep it in the diagnosis of some CA, neoplastic lesion with necrotic component.
I'm sure.
Not enhancing.
After descriptions, if you say summary, you will get diagnosis and you will speed up you will finish your case.
As it is non-enhancing, I would like to keep it in the diagnosis of pancreatic adenocarcinoma, sir.
How you know it is not enhancing?
Sir, I would like to see delayed images also in the pancreatic protocol, which we used to do.
Okay. So what's your differential now?
Sir, pancreatic CA with the provisional of pancreatic pseudocyst, but
where is pseudocyst? This is solid or cystic?
Sir, it is cystic, sir.
No.
Yes, sir.
No, it is not cystic. So this is solid.
Sir, it is.
This is cystic.
Yes, sir, it has some solid component in it. Sir, if you don't give the history of pancreatitis or any fever, debilitating condition, that it may be the walled-off necrosis, but as I'm not seeing peripancreatic fat strainings, so my first diagnosis will be pancreatic CA, sir.
Which is type of pancreatic CA? Pancreatic mean pancreatic cancer. So pancreatic cancer, it is lymphoma, it is adenocarcinoma.
Adenocarcinoma, sir, and also.
What's against adenocarcinoma?
Sir, it is non-enhancing CA of pancreas seen in the elderly patients.
This patient is 65. So in summary,
I would like to see its pre-contrast image also, whether it is having some calcification in it or not. If it
no
is
calcifications.
mucinous or serous. Yes, sir.
No calcifications. So I will describe it for you simply. I will say there is solid pancreatic head enhancing lesions. The remaining of the pancreas is unremarkable. I don't appreciate pancreatic duct dilatation in the provided images. I don't see fat surrounding. Fat surrounding the pancreas is clear. Vascular structure are grossly unremarkable. The visualized part of the pancreas in the arterial face, it is free from disease, no focal lesions. The visualized part of the peritoneal cavities and bowel lobes are unremarkable. Osseous structure grossly unremarkable. However, I will evaluate it in the bone window. So in summary, I'm dealing with solid pancreatic lesions. Solid pancreatic. So my differential diagnosis will include neuroendocrine tumor, lymphoma, pancreatic adenocarcinoma, and I will put solid type of serous cyst adenoma. Then I will put last one is what? Could be what?
Sir, what? Sir, I will like to see. I would like to see its CEA levels also correlate with the CEA levels also.
No. So neuroendocrine tumor.
Sir, they will enhance more abruptly. Sir, they will enhance more.
Yes. So neuroendocrine tumor, we have hypervascular, typical neuroendocrine tumor. We have atypical neuroendocrine tumor. We have functioning neuroendocrine tumor. We have a functioning or non-functioning neuroendocrine tumor.
Yes, sir. Functioning will be islet cells like insulinomas, glucogonomas.
All type of neuroendocrine tumor can be functional and can be non-functioning.
Right, sir.
So this is insulinoma. Okay, this is insulinoma.
Axial section CT scan with contrast taken at the level of the liver. I can see a distended stomach with thickening of its wall. Fluid is seen within the stomach. There is some irregularity noted within the wall of the stomach. It is displacing spleen posterolaterally. Do I have any other images or should I stick to that?
No, this one.
Okay. So seeing such a dilated stomach, I'm thinking of any pyloric obstruction.
Why you say this is distended stomach?
Because the walls because it is due to the location of the. Okay.
The stomach. This is a normal gastric wall.
Okay, normal. Okay. I'm seeing it in another lesion. It's in the retroperitoneum, which is the fat density.
This one.
Yeah, this one.
No, this is part of peritoneal.
Part of peritoneal. Okay. The wall of the stomach is irregular. With this this is an outpouching. This is a mass arising from the lateral wall from the greater curvature of the stomach. This is with fluid within it.
So this is the mass.
Yeah, this is the mass. Arising. This is an exophytic mass arising from the greater curvature of the stomach and displacing the posterior laterally. and the wall of the stomach, the greater curvature is slightly thickened with such an exophytic mass. I would keep the topmost differential of gastrointestinal stromal tumor. However, I would keep the other differential of adenocarcinoma and lymphoma, but those will be unlikely.
Yes, excellent. So this is large exophytic mass from the stomach with heterogeneous wall enhancement. This is a heterogeneous irregular necrotic part. It is containing air here. That's
Okay.
Communicating with the gastric cavities. There is here fast surrounding the peritoneal cavity. This is fast surrounding in the peritoneal cavities. The mass is completely exophytic with submucosal extensions to the mucosal cavities. The remaining of the pancreas is the remaining of the liver is unremarkable, and visualized osseous structures are unremarkable. So exophytic, large exophytic gastric lesions. So what's your differential diagnosis for large exophytic pancreatic lesion other than GIST?
The exophytic lymphomatous deposits, necrotic lymphomatous deposits will be in the next differential.
Excellent.
And
one disease. One disease.
One disease. Okay. Exophytic masses. I cannot think of any other differentials other than GIST and lymphomatic deposits.
Melanoma, metastasized melanoma tend to be exophytics and can cause complication and connection with the cavities.
Okay, thank you, sir.
Thank you very much. So this case.
Dr. Binish Hanif, you are next. Please take up this case.
Assalamu alaikum. This is axial CT image of pelvis with contrast. I can see there is kidney is seen in the right iliac fossa, and it shows mild hydronephrosis, and the colon appears thick-walled.
Okay. What's more?
Answer. So is there any history of transplant?
Don't ask for a history unless you want to confirm the diagnosis.
Okay.
Transplanted kidney. And you usually, if you want, as a radiologist, if you want anything from the physicians, any prior history to confirm, usually look at the hint from the images before asking the physicians. When you look the hint, when you pick it, the hint from the image, and you tell the physician's patient has history of so and so, believe me, he will trust you forever. Sometimes physician, he don't see the patient and he requests CT, requests lab and see the result, then he decides, even without examinations. If you see there is thinning of the muscles here, there is this muscle here is normal. There is here thinning of the muscle, that's indicating the previous history. So this patient, yes, have history of transplant. This study is so simple. Case is so simple.
So the colon is dilated and appears thick-walled, and there are also air lucences in the colon. So my diagnosis is colitis.
No, colitis secondary to what?
As there is history of transplantation, so patient might be receiving some immunosuppressant, so it can be neutropenic colitis.
What's more? This is in differential.
Sir, and differential would be inflammatory colitis and ischemic colitis.
The hint is in the image. So we have, this is the normal wall thickening.
Yes, sir.
This is abnormal.
Yes, sir.
So this is abnormal. This is abnormal. There is fat is not clear here.
Yes, sir, there is surrounding fat stranding. So,
So this-
diverticulitis.
Yes, this is diverticulitis. Chronic diverticulosis complicated by diverticulitis, no collection or free air in the provided images, right transplanted kidney, only lesion like related to secondary hyperparathyroidism or renal osteodystrophy. Okay?
Okay, sir.
Contrasted and CT scan axial images at the level of kidneys. The upper one is contrasted dense and the lower one is non-contrast image.
Which one? Which one? Sorry?
Sir, the lower one is non-contrast.
This is the not contrast?
No, sir, it's contrast and both are contrast.
What is this face and what is this?
This is upper one is arterial, and lower one is delayed or.
Yes, excellent. This is the contrast system. So what do you see?
Okay, there is a large hypodense area with central hyperdense linear hyperdensities are noted in the spleen. On the delayed images, the central hyperdensities are still seen, and the lesion is, appears to be slightly iso to hypodense on to the spleen.
So this is for our cases.
On the basis of my finding, likely it's splenic hydrated cyst.
No.
Oh, what's with central hyperdense and
you completely deviated from the pathology. So, because what's the mistake? The common mistake is people is not putting what?
Yes, sir.
Summary. If you put summary, so
Yep.
differential diagnosis, you keep it under this summary, under this category. If you say cystic pancreatic, cystic splenic lesion, you will put so and so and so and so. If you put solid pancreatic, solid splenic lesion, you will put so and so and so and so. Then you will put one diagnosis.
Okay. This appears to be a solid lesion with central hyperdensities. Could be a splenic hemangioma.
What else? What is the classic appearance of hemangioma, splenic hemangioma?
Sir, soft tissue mass with phlebolytes or
no.
Sir, could we put lymphoma?
What's more? So this is solid pancreatic.
ये है ही कंधो आर्टरी
पैसा उंदन ताकि 50 रुपए दो
तो ये मुझे बच्चों कमजोर सफा
Splenic lesions has central calcification with star appearance.
Star appearance, sir. Sir, it could be central store appearance. Sir, oncocytoma.
This is Sant lesion. This is typical appearance of Sant lesion.
Which lesion, sir?
Sant lesion.
Sorry, could not hear.
Sant lesion. Sclerosing, adenocarcinoma, nodular transformation of the spleen.
Okay. Okay, sir.
So I'm provided with coronal image of CT scan, arterial phase, in which I can see that there is an ill-defined hypodense area seen in the right lobe of the liver. It is not showing enhancement on arterial phase. I can also see cities in the pelvis, and the large bowel loops are also dilated with bowel wall thickening. There are also multiple large mesenteric lymph nodes noted. So can I see another image?
There is no image.
There is no image. My first differential is liver abscess. But with colitis in the large bowel.
Okay.
And multiple enlarged lymph nodes due to infection. And the liver is also enlarged.
So what's more? So in summary?
There is bowel wall thickening and large lymph nodes and an ill-defined area in the liver. So this is some infectious process.
The common mistake I noticed, there is nobody put the summary of abnormality or summary of findings. So I'm dealing with so and so and so and so. If you put summary, then you will put the differential diagnosis. You will reach to, I'm sure you will reach to the final diagnosis.
Okay. This is inflammatory bowel disease with abscesses in the liver.
You start right and then you deviate it.
Okay.
So to make it easy, we have diffuse bowel thickening, diffuse bowel, large bowel thickening, narrowing, dominant structure here, have ascites, local lymphadenopathy. Okay, we have mass here in the cecum and the /ascending colon near to the TI. This is the TI. This is it. Okay. So it's showing mass with calcifications, ascites, and we have large hepatic lesions. So in summary, we have colitis with masses and liver lesions. This is my summary. So colitis, could be infectious, inflammatory.
So this is infectious.
Why infectious?
Sir, because in infectious colitis, we have enlarged lymph nodes.
What about tumor? Or what about ulcerative colitis?
Yeah, in ulcerative colitis also.
So
he can have lymph nodes.
So what's your next step in this patient?
Sir, we will do the colonoscopic guided biopsy
For what?
for the colon lesion
Okay.
to rule out whether this is neoplastic process or if this is infectious thickening.
So this is patient pancreatitis. Okay. This is featureless colon.
Yes.
So this likely is patient is thin. Usual inflammatory disease patient thin. So this is likely ulcerative colitis.
Yes.
This is focal stricture could be related to underlying tumor. Focal structure, dominant structure, this is tumor until proven otherwise. This is another mass here, so this is 100%, this is tumor.
Okay.
So this tumor patient has solitary liver lesion. So what's your differential diagnosis of liver lesion in patient with inflammatory bowel disease? Ulcerative colitis specifically.
Sir, sclerosing cholangitis and also pyogenic cholangitis would be with this. But if the patient...
Differential diagnosis for hepatic lesions in the patient with inflammatory bowel disease. So on.
Sir, first is association of inflammatory bowel disease is sclerosing cholangitis.
Okay, sclerosing cholangitis can cause what?
It can cause cholangiocarcinoma.
Excellent, cholangiocarcinoma. So first is cholangiocarcinoma. Second?
Sir, pyogenic cholangitis.
Pyogenic cholangitis patient, they are immunocompromised. So
yes.
Immunosuppressive. Third? Could be metastatic from adenocarcinoma or colon complication of inflammatory bowel disease. They have high chance for develop cancer in the colon, or that's can metastasize. Okay.
Okay.
One. Lymphoma.
Hello.
Yes.
Yes.
Fourth one is lymphoma. Patient with inflammatory bowel disease, they has risk for lymphoma.
Okay.
Yes. Less common. What? From differential also can less likely.
So less likely hepatocellular carcinoma.
No. Tuberculoma, abscess formation.
Tuberculoma, abscess.
Or tuberculosis. Okay. So now, if you say for the physician, this is pyogenic abscess, he will treat patient with antibiotic, then he will remove this cancer. If you say this is cancer, so this patient has chemotherapy. If say this is likely cholangiocarcinoma, this is different cancer, they will resect this and they may resect this or do local treatment for this. So what is your next step?
So next step is ERCP.
Huh?
Next step is would be ERCP.
Why ERCP?
Sir, on ERCP, we can see that if there is cholangiocarcinoma or there is sclerosing cholangitis.
No, patient has biliary dilatation. So no, this is patient ulcerative colitis with the sclerosing cholangitis. So we have already, this is either primary cholangiocarcinoma or metastatic colon cancer or pyogenic abscess. What you will do?
Sir, I'll do MR of liver.
This is MRI.
Okay, so this is T2 weighted image, axial image of liver. On this, I can see that the lesion is giving mixed intensity, hyper intense to liver. And its periphery is irregular. So in this case, my differential would be cholangiocarcinoma. And I would like to check the diffusion weighted image to see if it's abscess.
So excellent. This is the tumor, has signal intensity of intermediate signal intensity near to the spleen. That's indicated it is not fluid. This is tumor signal intensity, is not abscesses. This has nodular enhancement. This is with cancer. And patient, if you see here, patient has a large right hepatic lobe. sorry, left hepatic lobe, here a large left hepatic lobe
Yes.
with cavernous transformation of the portal system that indicate chronicity. So this is favor the primary cholangiocarcinoma of the peripheral rather than metastasizing colon cancer. I will biopsy this lesion to see this is cholangio or colon cancer.